Good morning, ladies and gentlemen. Welcome to the week Best Hospital Survey Awards 2020. I'm Matthew D. George, Deputy News Editor of the Week, and your host for this morning. On behalf of the Editor of the Week, Mr. Philip Matthew, the Editor in Charge, Mr. V.S. Jayachandran, and all of us here at the week, let me thank you for making time to join us this morning. This year, the medical world was pushed into the hot seat, and how? I'm sure you'll agree when I say that there's never been a better time to show our appreciation to our brothers and sisters in the medical fraternity. So, to everyone, from those in corner offices in hospitals to support staff who help maintain hygiene, here's a heartfelt thank you from all of us at the week. The week has been publishing its annual Best Hospital Special issue since 2006. Our sole intention has always been to help our readers make an informed choice. The cover story has always been accompanied by a survey done by an independent agency. The editorial, circulation, and marketing divisions have always distanced themselves from the survey. We have always kept it that way, and we would like to do so in future as well. And that is exactly what puts the week Best Hospital Survey among India's most trusted hospital surveys. Please allow me to take a quick moment to welcome our keynote speaker and panelists, so they'll be introduced in detail shortly. Dr. Randeep Guleria, Director, All India Institute of Medical Science, New Delhi, is our keynote speaker. Welcome, Doctor. Thank you so much for being our well-wisher of the week and for taking time out on a Monday morning to be with us. Our panelists for the day are Dr. Santosh Shetty, Executive Director and CEO, Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. Dr. Bobby John, Global Health Advocate and Editor, Journal of Development Policy and Practice. Dr. H. Sudarshan Balal, Chairman, Manipal Hospitals. Dr. Naresh Trehan, Chairman and Chief Cardiac Surgeon, Medanta, the MedCity. Welcome and thank you so much for your time, Dr. Shetty, Dr. John, Dr. Balal, and Dr. Trehan. My colleague, Special Correspondent Namita Kohli, will introduce you in detail when she opens the panel. Welcome to you too, Namita. A quick welcome also to Mr. Bikash Padi, Research Director of Hamsa Research. Thank you for all the number crunching and for being here, Mr. Padi. Now it's my pleasure to welcome Dr. Randeep Guleria, keynote speaker for the morning. I would not be overstating it if I say that very few medical families in India come as highly accomplished as the Gulerias of Kangra, Himachal Pradesh. The patriarch of the family, Dr. J.S. Guleria, is a gifted cardiologist and a general physician. He was former dean and professor at the All India Institute of Medical Science, New Delhi. Just to give a background, Dr. Guleria Sr. was with our first Prime Minister during his last days. He was also the first doctor to see Mrs. Indira Gandhi when she was wheeled into AIIMS on that fateful day in October 1984. He's among the people who built AIIMS into what it is today. And I quote him, "When I joined AIIMS, there was no building or hospital. I remember when we opened the cardiology lab at AIIMS, we swept the floors ourselves. We built the institution brick by brick." That is the level of service that runs in the Guleria family. So it is small wonder to me that his son, who had a ringside view of his father's work at AIIMS, today sits in the director's chair. Dr. Randeep Guleria is the tip of the spear in India's medical response to COVID-19. An icon in his own right, Dr. Randeep headed the AIIMS Department of Pulmonology and Sleep Disorders and was personal doctor to former Prime Minister Atal Bihari Vajpayee. He consults for many bodies worldwide, and I can go on for a long time, so let me just mention two. The WHO has him on its scientific advisory group of experts on immunization and influenza vaccination, and the International Atomic Energy Agency, Vienna, consults him on issues related to radiation protection. A family that has cared for three Bharat Ratnas is an uncommon family indeed. Dr. Guleria Senior for Panditji and Indraji, and Dr. Randeep for Atalji. As a mark of the nation's gratitude, both doctors have been honored with the Padma Shri, and Dr. Randeep additionally with the B.C. Roy Award. Dr. Randeep has been a well-wisher of the week, and we have his interview in the latest issue as well. It is my honor and great pleasure to invite Dr. Randeep Guleria, Director, AIIMS Delhi, to deliver the keynote address this morning. Over to you, Dr. Guleria.
Mr. Matthew George thank you very much, Mr. Matthew George, for those kind words. I really don't deserve them. I think we've all just done our job, and that's what really matters. Um, I would like to start by thanking the week for holding this virtual meeting in these challenging times and for inviting me to give the keynote address. COVID-19 has taught us a lot, but I think it's also taught us how to be innovative, and this is a classical example of how we've continued our activities, whether it be trying to see the best hospitals in the country, or to continue business as usual as much as possible, with the pandemic still going strong as far as India is concerned. I would basically be trying to talk on what the pandemic has really done as far as healthcare is concerned, focusing on hospitals, because this is basically the session is on hospital care, and also what are the learnings for the future. So I think 4 or 5 things that the pandemic has taught us as far as hospitals are concerned is that when this pandemic struck, we were really not prepared in terms of the challenges that hospitals had to face. And we realized that we had to be innovative, we had to have resilience, we had to have teamwork, and we did have to have a never give up attitude. And these are the 4 things that I think we really needed to build our healthcare facilities in hospitals on. When I talk of innovation, I remember in February and end of February, beginning of March, when we started our meetings, our daily meetings, to really discuss how do we prepare for this pandemic. There were a lot of suggestions, and we realized that we cannot mix COVID and non-COVID patients together. There was a whole challenge, and we therefore set up separate COVID care facilities. We had a lockdown. The trauma care had come down because of the lockdown. There were less trauma patients, so we quickly converted our trauma center into a COVID hospital. We had the NCI, the National Cancer Institute in Jhajjar, which is also a part of AIIMS, a 700-bedded cancer hospital, which has just started with about 150, 200 beds. We quickly converted and got those 700 beds operational so that we could actually have almost 1,700 beds ready for COVID positive patients. This was the innovation that was required as far as infrastructure was concerned. It was a huge challenge. You needed equipment, you needed manpower, you needed to have facilities. How do you do this overnight or within a week or 10 days? And I think most hospitals across the country took up this challenge and became more and more innovative. We also realized that there was a lot of fear among healthcare workers, and you had to really focus on that. How do we protect our healthcare workers? And training became a very important part, and this pandemic taught us about. We've never been that focused on infection control in the past, whether it be our nurses, whether it be our sanitation workers, whether it be our other officers, our residents. We assume that everyone knows about infection control. But this pandemic told us that we really need to focus a lot as far as infection control practices are concerned. We developed modules, and for months, every day, morning, evening, our hospital infection control team had training sessions for all the nurses in the hospital, whether you were in the COVID or non-COVID area, all the residents, doctors, sanitation workers, OT technicians, even the security guards, on simple things, hand washing. Most people think they know how to wash their hands properly. But if you were to really test it and see, you would find that more than 60-70% really have no idea. Cough etiquettes. Most people really don't have good cough etiquettes. And then the donning and doffing of PPEs, and how do we protect ourselves when we are coming in contact with these infectious patients. So this is the second part that we really had to innovate and do that quickly. AIIMS being an academic institute, we also decided that research is going to be a very important component. We have to look at how are things in our own country. And way back in March itself, we started research projects. We built a research consortium, and we also said that we cannot wait for money to come from outside. And therefore, AIIMS used its own funds to support research. Intramural grants were given, and almost 50 projects were actually sanctioned way back in March, looking at various aspects of COVID-19. And then, of course, we had this whole issue of shortage of PPEs, N95s, and a lot of innovations were done. We did a project where we tried to see how could we recycle PPEs. That if you had worn a PPE and you came out and it was in a good condition, could you really recycle it clean it and make sure that it was free from virus and still could be reused. This paper has also been published. And then, of course, the healthcare itself changed a lot in terms of telemedicine and teleconsultation, which also became important. So this is the innovation that we actually were able to do. Then we had to look at the second part, the resilience that we needed. Like I said, there was a lot of fear among the healthcare workers. I remember in the early days, one resident told me that, sir, she was in anesthesia, and she said, sir, I don't mind working in this COVID hospital, but I'm the only daughter of my parents. What will happen to my parents if I get COVID and die? This was the type of fear that residents had. A nursing officer, it took me 3 hours to really console her because she had seen a patient who was suspected to be COVID positive. That patient actually turned out to be COVID negative. She refused to go home and she kept crying that this patient may be COVID and I'm totally infected and my parents at home will get infected. This was the type of fear that we had at that point in time. And the stigma that existed because of the fear of COVID, not only among patients, not only among the healthcare workers, but among society itself. We really had to work hard to get over that. Talk to people, communicate, build confidence, make them feel that this is not that bad. This was a huge challenge that we had. And then I think the other important issue was teamwork. No hospital could have gone through managing pandemic if they did not have aggressive teamwork in place. And that is the other very, very important thing, whether it be the residents, whether it be the sanitation worker, the OT technicians. And I think we used to have a meeting, and we have a meeting every day in the morning with all of them to discuss issues. And you realize that there are certain issues which we as faculty have never really thought of, which the sanitary worker or the hospital attendant will tell you that these are the problems in the hospital which are causing infection, or these are issues we need to resolve them. So sometimes it's working together and listening to even the person at the lowest level in a pandemic is very, very important. So working as a team is the other thing that we really realized. And like I said, a never give up attitude, because we have now coming into a stage where healthcare workers are going to what is COVID fatigue. So how do we really motivate them? How do we de-stress them? How do we develop a plan to rotate them so that people are able to get some time off? And this is actually something which is creating a toll on the health system right now. So that is the other thing that we need to really look at. Finally, what are the learnings for the future? I think what has happened with this pandemic is it has changed the way health will be, or the healthcare facilities will be in the future. Hospitals will have to focus more and more on infection control. We probably have not done that, especially public sector hospitals. Public sector hospitals have never really looked at infection control, whether it be ventilation in the OPDs, whether it be the corridors, or whether it be the indoor areas, or having doors which are where there is a no-touch technique. So simple things like that, which are doable now, have never been looked at in the public sector hospitals. So I think this will change in a big way. Secondly, the way we provide healthcare is going to change dramatically. Telehealth will become more and more important now. We will have to start looking at video conference rooms in the OPDs. How do we really have follow-ups which are more through teleconsultations rather than regular consultations? Looking at IT and digital health, which is part of the Prime Minister's mission. So how do we really incorporate that both in the public and the private sector? And I think we will have to start looking at more and more daycare facilities. A lot of procedures are now daycare, and the whole infrastructure will have to change to really focus more on daycare facilities for the future. So hospital planning will change dramatically. And I think another thing that the pandemic has taught us is that, especially in tertiary and large hospitals, the focus is becoming more and more on critical care. We've had whole issues of ICU beds and shortage of ICU beds. So we will have to develop strategies where either we increase the ICU beds, or we have the facility to convert HDU beds or wards into ICUs. Because you can have a ward which may have all the facilities, central oxygen suction and other things, and can quickly be converted to manage patients who need ventilatory support. So how can we upscale our hospitals from what they have right now to let's say 50% or 40% of beds which could look after critically ill patients if that need arises. That is something that has really going to happen in a big way. I also feel that there's going to be restructuring as far as the healthcare system is concerned. We really need to focus on ancillary staff being trained enough to be able to provide proper healthcare. It's not going to be enough just to say that doctors will do everything or this will be done only by the residents. There has to be a group or teamwork where there has to be delegation of work, whether it be nursing officers or other trained personnel who can come in and really help out as far as the healthcare system is concerned. Before I finish, I'd just like to point out two or other important issues. One is that I think what this pandemic has taught us is that preventive health still is very, very important. Whether it be hygiene, whether it be cough etiquettes, those are going to become more and more important. And we will have to start focusing on home care, point of care testing. How can we provide adequate home care so that we can decrease the load of patients coming to the hospital, and only those who really need to be in the hospital can be managed in the hospital. Many of them can be sort of looked after using technology, using telehealth, and be provided proper care as at homes rather than having to come to the hospital. And as we plan for the future, we have to really remember that this pandemic doesn't mean that there won't be another in the coming years. The last 15, 20 years have actually been a warning for us. We've had outbreaks of SARS, we had an H5N1 bird flu outbreak, we had the H1N1 pandemic, outbreaks of Zika, Ebola, and MERS coronavirus. So I think there has been enough warning in the last 15 years that the world has become smaller, and there are viruses which are going to jump species and cause pandemics even in the future. So we have to plan for the future for outbreaks which may happen subsequently, and also be able to look at how we can use technology, especially artificial intelligence, to help us in better management, better surveillance, and be prepared for any outbreak in the future. So these were my thoughts, and I put them across. I would be very happy if during the panel discussion we can have comments from the others. So thank you very much.
Thank you so much, Dr. Guleria, for that insightful address covering everything from daycare facilities to teamwork, critical care improvement, conversion of beds, preventive health care, home care, and also the all important part of reassuring members in your own team. Thank you so much for taking time out this morning. Now, with your permission, we'll move on to the panel discussion. And it's my pleasure to welcome my colleague, Special Correspondent Namita Kohli, to open the panel discussion this morning. A Nehru Fulbright Fellow, Namita is an accomplished health reporter. So, without much ado, let me hand over the panel discussion session to her. Over to you, Namita.
Thank you, Matthew, for the introduction. And we are fortunate today to have a distinguished panel with us to discuss some of the very crucial issues that are just likely to come up in the coming months as well. As we know, we are at a crucial point in the pandemic, with several states again reporting surges, including Delhi, that is having a particularly tough time. Health systems in the past few months have been challenged both from the public sector and from the private sector. From infection control practices to the safety of healthcare staff, as Dr. Guleria mentioned, to hospital designs. Hospitals in the country, across the country, have had to really realign themselves to battle this unexpected pandemic. There have been several challenges and opportunities for the future as well. So, without further elaborating on the challenges, let me just introduce our distinguished panel today. We have with us Dr. Sudarshan Balal, who is the chairman of Manipal Hospitals. We have Dr. Santosh Shetty, Executive Director and CEO, Kokilaben Dhirubhai Ambani Hospital in Mumbai. And we have Dr. Bobby John, who's a global health advocate. Dr. John works as a facilitator at the intersection of policy, technology, and finance to enable health outcomes at individual, community, and global levels. So I'll just pick it up from the last, really, Dr. John. Now we've heard Dr. Guleria speak elaborately on the challenges from the public sector hospitals. But the pandemic has been really a wake-up call for our health systems, not just in India, but also at the global level. What has been the nature of this wake-up call? Could you elaborate on that? And how do you see our health systems having responded to in the last few months to this extraordinary challenge? Over to you, Dr. John.
Thank you, Namita, for inviting me, the We Group, for this opportunity. I just want to pick up from where Dr. Guleria left off, and I was listening to him when he underscored a couple of times the question around infection control, and in my head, a couple of themes began playing, and so therefore I want to begin there and then I'll respond to your question. It seems that we seem to be rediscovering infection control with every new wave of or a new challenge that comes along our way. The last time with HIV, we all discovered universal precautions. And my counterfactual for that was, while we were doing so much for HIV, nothing much seemed to be happening concurrently on the Hep B, Hep C side. Same modes of transmission, we were doing universal infection control on one side, and the other one seemed to be escaping between the cracks. So somewhere along the line, we discover universal precautions. It's uneven. Working backwards in time, going back 150 years nearly, Semmelweis taught us hand washing. Puerperal sepsis came along, and we kind of figured out that if we washed hands before handling babies or pregnant women or postpartum women, we would actually reduce mortality. Seems to be lessons that we need to be learning over and over again. Tuberculosis and SARS in the recent past taught us the value of cough etiquette and using of masks. We seem to need to rediscover this all over again. And so therefore, as a public health thinker for myself, I see this as a brilliant opportunity of re-underscoring some of the very basics, not only at the hospital level, but also at the community level, that will allow for better health outcomes as we go forward. What are the challenges that we have faced? Are they different from other countries? No. Almost all of humanity, irrespective of where in geography we find ourselves on this blue planet, we have had similar challenges. Our responses may have differed in a couple of points. We may have been relatively slow in recognizing the epidemiological signals that came through. Some countries were quicker. Some institutions were quicker. We, in a generalized sense, were slower in picking up the signal. And so therefore, our response was a lot more slower to start with. This is not an indictment of any one part, whether the public or the private sector. It's generally the way things were. Running on from that was the uncertainty around the scale of the response required. Was it going to be one case, 100 cases, 1,000, several orders of magnitude over that? We seem to be uncertain about the scale at which the threat was being posed, and therefore the scale of the response that was required. Should we have been preparing for tens of thousands of beds where people could be moved to? Should we have been preparing for tens of thousands of beds where there was ability to support people with oxygen? That scale was a relative uncertain one. And so therefore, we then have a lag of the response. And the last bit is the unevenness of the surge in capacity. There were private sector institutions that scaled up within the first few weeks. They were up and ready and able to take on whatever was being pushed. And even though there was great uncertainty over what was this disease all about, what was the kind of treatment, what could be the outcomes, with all those uncertainties, healthcare workers, private sector, public sector, all came in, but that was very, very uneven. Could it have been more even? Not necessarily. We needed better understanding of the signal. We needed better understanding of the scale that was required, and therefore we could have evened it out. What has it been? And I close here with this. In the same way that the virus has proven to be a surge requirement on the immunological systems of the individual, it has been a surge of a challenge onto our public health systems. And when I say public health systems, it's not just the government. We are one health system. We may be delivered in the public sector with taxpayer money. We may be delivered out of pocket by the private sector, or we may be underwritten by certain insurance mechanisms, either in the public or the private sector. But all of us together have had a collective surge, and we need to figure out how we manage this as we go forward.
Right. Several important points, Dr. John. I'm happy to introduce Dr. Naresh Trehan, who's just now joined us. Dr. Trehan is the chairman of Medanta Medicity and really needs no introduction as such. So, welcome, Dr. Trehan. Do we have you? Can you hear us? Okay, so while Dr. Trehan joins us, I'll move to Dr. Sudarshan. The unevenness, as Dr. John said, the uncertainty of the pandemic, the scale at which it came and sort of challenged us all. Dr. Sudarshan, would you like to share how your chain of hospitals has really handled this unprecedented surge?
Good morning, Namita. Thank you very much to Dr. Matthew and the WEEK group of organizations for organizing this during this pandemic. And it's a pleasure to be here. It was wonderful listening to our keynote speaker, Dr. Guleria. I've been in the healthcare industry for almost 5 decades, and never in my life have I seen a pandemic like this. While the COVID-19 has impacted the global health systems and highlighted the underlying inadequacies with respect to an effective response to the pandemic, it is accelerating one of the greatest workplace transformations I have seen in my lifetime. Organizations have constantly been reinventing practically every process and policy that we have had in the past. And this is what we need to look beyond for the future, even when COVID is gone. One thing that we have realized, which I think almost all countries have realized unequivocally, is that the country is only as strong as its healthcare is. However mighty your military might be, however big your economy might be, you're only as strong as your economy may be. To me, the biggest boost, or what I call as a silver lining in the corona clouds, was the boost to the digital health space. For years, maybe decades, we were mired in regulatory issues. And believe me, in a week in March, all these regulatory issues were taken care of, and digital health got one of the biggest boosts in the healthcare in decades in the past. Now, teleconsults have become a routine, e-consults, virtual consults, everything is something that even the common man talks about. And to me, one of the biggest advantage of this is that it has addressed what we would call the rural health famine. And this is a word that's coined because almost all of healthcare, which is 60% of the hospitals, 75% of the pharma, and 80% of the doctors, are in cities. Hardly anyone in the rural areas, and they have nowhere to go. But at least now with digital health, they have access to healthcare. And I believe over close to 50 million people have accessed healthcare online in the last few months. So that's a major boost, and I'm sure it will be here to stay. So the divide between the urban and the rural areas will be sorted out to some extent. It will also sort out some of the personnel shortages we have. We don't have enough doctors, nurses, pharmacists, so on and so forth. So I think digital health will also bridge that gap to a large extent. The other thing that we have learned is that we were basically essentially an inpatient-based care in India, somewhat a reflection of what's happening in the US. And now we have learned that care of patients need not necessarily be inpatient. When COVID started, everyone was rushed into hospitals and kept there for 2 weeks, irrespective of whether they needed it or not. Now we are starting looking at patients, outpatients, daycare, COVID care centers, and of course, finally, home care. And there are very good monitoring devices where you can monitor someone at home. So this will definitely ease the number of beds that are available, because even in the future for other illnesses, most of them may not require admissions and can be managed as outpatient or home care, and that's another big lesson we have learned. The third and foremost, in a country like ours, where about 70% or more of healthcare is in the private sector, it is absolutely necessary that the private sector and the public sector work together in crisis and pandemics like this. And we have learned this time how to work with the government. Of course, there were some hiccups earlier, but I think we have a better understanding of each other. And there's been a reasonably good working pattern between the government and the private sector. And also many weaknesses in the private health, in the healthcare sector of the country, which we have seen now, like primary care, preventive care, so on and so forth, can be strengthened. And lastly, I think what is very important is we need to know the importance of the universal health coverage. Honorable Prime Minister has already come with Ayushman Bharat for the weaker sections of the society, and it's been extended. But we are missing a large number of the middle class, what I call as the missing middle. So we should come up with a robust insurance coverage for everyone concerned. Last but not the least, do not forget some of the lessons that were useful for us during the COVID era. One, of course, the traffic was less, our carbon footprint in the world was far, far better. And there has been a tectonic shift in the way we view healthcare. And this will continue in the future too, I suppose. Thank you.
Thank you, Dr. Sudarshan. Patient care without being impatient, that's quite the thing that stuck with me throughout your opening remarks. We have Dr. Naresh Trehan with us. Dr. Trehan, as I mentioned, really needs no introduction. Dr. Trehan is the chairman of Medanta Medicity, and we're happy to have you, sir, on the panel today. So we're just opening with, the kind of challenges that, hospital systems have had to face with this sudden surge of this unprecedented nature, unprecedented scale. So really how our systems have handled it and what have been the challenges and the opportunities. Dr. Trehan, would like to hear from you.
So if you look at it, basically, with this pandemic having hit us in full blast, we started with not knowing much about it and being totally ill-prepared. With the wisdom of severe lockdown for 3 months, that gave us some elbow room to create that infrastructure that we needed badly, the concomitant the equipments that we needed, like the ventilators and the PPEs and the masks and all the other paraphernalia. So I must say that it showed a huge character of our country. To say, one, we could all come together very quickly. That is the government, the private sector, healthcare providers, and the medtech industry, and also industry at large. So if you see how the repurposing was done, very quickly, that helped to put India on a firm footing to handle the onslaught that was expected once the lockdown was over. Okay. Now, it's a three-way fight. One is what the government can do, the other what the frontline health workers can do, and the third is what the public can do. And the most responsible part, or the largest part, is what the public can do. So, with the severity of the lockdown, it caused lot of disruption. It caused economic hardship on many people. The industry suffered. Everybody suffered in a way. But at the same time, we knew that this unlocking had to happen at some point, whether it was 3 months or 4 months or 5 months or gradual. And all this planning, I must say, was done very well. I think India has handled it quite well, given the size of our population and the diversity in our population. See, so it's not like Sweden, where you say everybody's got the same level of education and same economic status. We have so many tiers in our life, as far as economic status is concerned, as far as education is concerned, languages, you name it, and habitats, they're all so diverse. So then to be able to pull it all together, we have had spurts. Now this is the third wave that we are suffering in some cities. We have gone through this sequentially, where in one area it becomes so severe that the infrastructure creaks at the edges. Delhi is going through that right now, the NCR area. At one point, Bangalore was in that shape. At another point, Mumbai was, and then now I'm told, and Santosh would know better, that Mumbai is creeping up back again, which looked like 200-300 cases. Now it's back to 1,200 cases. So what does it teach us? It teaches us two things. One, this is a virus which we don't understand completely. We are struggling at every level. So which medicines to use, what sequence to use, how effective they are, then the vaccine being looked out for. So we don't have a real weapon against the virus yet. Having said that, we have two very important considerations to keep in mind. One is that India cannot afford an economic lockdown for long periods of time. If you compare it to, say, UK, they said we'll pay 80% of the salaries of the employees. I mean, they had enough reserve. I mean, their population is almost 1/8 of ours, right? Or maybe even less. So the point is, given our demographics, given our country's character, the only weapon that we have is that somehow people understand the responsibility of just practicing those three things that are so central to this fight. Now, if we cannot get that into people's heads enough, we are going to continue to have wave after wave. And as you know, even when vaccine comes, it's going to be many, many months before we can vaccinate everybody, and we don't even know how long it will last. So there are many, many question marks facing us today. And at the end of it, if we do not behave ourselves, in spite of the government being proactive, in spite of doing everything what the frontline health workers have done, you must say it is 8 months, is the 9th month now. Hospitals are under severe financial pressure. The frontline health workers are basically risking their life, and you know many of them have gotten sick and many of them have fallen. Now, if this continues, there will be a huge drop-off in the sense of fatigue will take care, people will lose their immunity in the healthcare workers, there will be more sick people. So we need to be we are at a very critical juncture today. How irresponsible the behavior has been at all levels. And I'm not saying that it's only the educated or the uneducated. The educated are also in this fatigue showed very irresponsible behavior. So how we break it into people's heads that look, you must, the virus is still around and it's full and in its full rage. So stop being stupid. I could use many stronger words. I'm using the mildest word. That if people do not behave themselves, they will suffer. And I'll tell you one thing, that misconception that young people will get it and they will recover and they'll be okay. You should look at how many of them have fallen, how many of them, their lungs have been compromised for life. They have a whole life of being sick. They may have survived, but they have survived with one leg. So do not have this false impression that, oh, I'm young, I'll go through. Yes, 90% will. But that 10% who will suffer, you don't know who the bullet will hit. So the point is, again and again, the only thing we can do, the only thing government can do, the only thing media can do is to make this message large as life every day, every minute that we can find, because it is a national emergency. If we don't defeat this today, it has an R factor of 3. That means it will keep multiplying, and we will not be able to contain it. So what has happened? We are suffering from, I think, in Delhi area or north, we are suffering from the festivities of Dussehra and Diwali, where if you look at pictures, video clippings of marketplaces where people, I don't know what they were thinking. And they are flooding. They're flooding the hospitals. We don't have any beds. So there are lots of consequences to this. So my message is, okay, we will recover. Our business people, our entrepreneurs, our government is actually done a great job, I must say. Our economy still looks the stock market looks great, but another shutdown of industry because of all this and stuff like that, we will not be able to bear that burden. So if I'm not clear, I don't know how to be more clear without using words which I should not. So I know my three colleagues are on the panel whose picture I can see. There may be many who I don't see, but this is a good representation. Bangalore, Mumbai, Delhi, the three in focus. So Bilal, you're looking good. So is Santosh. It's a pleasure to be here. Any questions you may have, I'll answer. Otherwise, I'm going to go back to doing some work.
Yes, Dr. Trehan, definitely would like to come back with questions for you, but I'll complete the first round and we have Dr. Santosh Shetty. Dr. Shetty, now, as Dr. Trehan mentioned, Mumbai again preparing to get overwhelmed and battling as the entire country is a relentless virus, how you mentioned to me the other day. So how have systems responded? How have your systems responded from infection control to hospital designs, really? Dr. Shetty, over to you.
Thank you, Namita. And at the outset, I'd like to thank the week for inviting me for this panel discussion. Like you most appropriately put it, I mean, it's a relentless virus, and we've gone through multiple phases in the last 8 to 9 months. I mean, the first phase was, that of scarcity. So starting from scarcity of information about the virus, all that we knew was the scenes that we had seen, in the US, New York, Italy, people dying on the roads, no beds available, the scarcity of PPEs, scarcity of N95 masks, scarcity of testing kits. So, you started from that phase, and this scarcity of information meant that there was so much of paranoia, hysteria in the minds of the healthcare workers and of the society in general. So healthcare workers very apprehensive about coming to work, not out of fear of themselves, but for the fear of their parents back home, for the fear of their children back home. And what the lockdown also meant was that public transport was shut off. So cities like Mumbai, where local trains are the heart of transport, became a huge challenge because it was very difficult to get healthcare workers to travel all the way. So one of the biggest challenges for us was to make sure that we had enough personnel at the hospital to take care. So we had to organize private transport to get them from different parts of the city. To manage the surge, Maharashtra was amongst the first states to face the brunt, like you appropriately put it. And the government very soon realized that it has to be done jointly with public and private sector getting together. So each hospital had to basically chip in and decide on the number of beds that they could offer, and the number of patients that they could see, both ICU as well as ward patients. And together we could create over 4,000 to 5,000 beds in the private sector across various hospitals, from the medium-sized to the large hospitals. That basically helped in making sure that every patient had access to a hospital bed. I still remember our first meeting with the health secretary and the Mumbai commissioner, and he said, I do not want people dying on the streets. So that was something that I think we learned to work very well with the public and the private sector together. I think that's one big achievement that has happened, as Dr. Ballal pointed out, that this has definitely taught us as to how the public and private sector can come together. The other big issue is that, we've been talking of pandemics in the last 2 decades, but we've been focusing more on the pandemics of the diseases of lifestyle, the cardiac, the cancer, the diabetes, those pandemics. Rightly so, because the number of cases have gone up there. But the infective pandemics were something that we never really thought, we would see anything of this size or scale. I mean, 55 million cases. And I mean, in India, you're talking of 9 million cases. I don't think a year ago when the first case came out in Wuhan, we would have ever thought that anything like this would be seen in India. And something which would stay on for so long, like what Dr. Trehan pointed out. I mean, COVID fatigue is something that we are seeing across healthcare workers, because we are prepared to handle all kinds of disasters. Being accredited organizations, we have structures in place, we know how to handle disasters. But to see something which is so relentless, 9 months still no end in sight, surges coming and going, is something that I don't think any system has been prepared for. The other part that this pandemic has definitely highlighted is the focus on infection control. It's something that, was always nice to talk about, but not really implemented across the whole section. This is something that I think has really come into focus. Institutions, both public and private, are looking at infection control in a very big way. Resources are being committed towards infection control because we realize that it's very important to protect patients. Like you said, healthcare design is something which has come into focus because hybrid hospitals like ours, for example, we are treating both COVID as well as non-COVID patients. So how do you ensure that the COVID patients are well looked after? At the same time, the non-COVID patients, the cancer patients, the cardiac patients, the stroke patients, how are they looked after and how are they also protected from COVID is something that has come to the limelight. So going forward, healthcare design, hospital design will have to incorporate some of those things. So we'll have to realize that when we get these pandemics, we have to have the flexibility in design to take care of these infected patients. We have to realize that these patients not necessarily have to be in ICUs or wards, but they may have to go to operation theater, they may have to go to cath lab, they may have to get scans done, they may have to come through emergency. So each of these areas needs to have the capability to handle these patients. At the same time, avoid cross transmission, avoid transmission of these infections to otherwise non-COVID patients suffering from other conditions. That's something that has been thought. So designs in the future will have to have that flexibility. Ours being a relatively newer hospital, we had a lot of these things in place like negative pressure rooms, negative pressure ICUs, but not something to be able to cope up of this size and scale. So what this has taught us is that we have to have the flexibility to be able to convert large parts of the hospitals into positive or negative pressure areas to be able to take care of these kind of surges. So I would just like to summarize by saying that the pandemic has taught us to be resilient, to be adaptable, and also the need to be flexible going forward. But it has also exposed a lot of chinks in the armor of the healthcare, not just in India, but globally. So we have to again go back to the drawing board, make sure that we have the flexibility as we move forward to handle these kind of pandemics. Thank you.
Thank you, Dr. Shetty, for that. I'll take off from the flexibility part and the sort of ongoing changes, the realignments that you suggest are going to be not just for now, but rather they will be something that will continue. And I'd like our panelists to sort of take off from there to how this will really affect the price points, the realignment in the way we imagined healthcare, in the way you've planned your economics is now going to be again restructured. So that restructuring would mean for the patient, perhaps again price point renegotiation, or we've already heard in the pandemic issues with prices that have been worked out between the government, different state governments and hospitals. But what does this mean for patient care and affordability in patient care as hospital systems realign themselves and possibly add costs? So, Dr. Trehan, yes, Dr. Trehan, we've taken off from Dr. Shetty's opening remarks on the flexibility and the realignment of health systems and hospital structures. That's going to really continue from now on. It's not going to be a one-off thing. Now that will affect the economics of healthcare, of hospital systems, and boiling down to patients, to the issue of patient affordability. Already in the pandemic, we've had these discussions on affordability, on your costs having to be renegotiated and possibly come up, and the government stepping in and stepping back. So, would you like to comment on the issue of affordability that's now going to be at the forefront from a patient care perspective, from a patient perspective?
See, I would say, Namita, the issue is not affordability. The issue is transparency. When we want to build this country into a transparent, in daylight transactions, right? So the point today is that there has been a lot of, it's like cross currents. Cross currents are created by the following facts. One is the fact that we have a country which has a very large population, which is disenfranchised in a way from the economic cycle. Second, we have a large middle class, which you can stratify them as middle, lower, higher, or doesn't make any difference. And then we have paid people who have done reasonably well economically. Okay. So you can't paint the whole country with the same brush. That is the economic side of it. The medical side of it is that we have double the burden of disease that we should have. No sanitation, it's coming slowly. Hygiene is very poor. The infectious diseases are not well controlled. And on top of that, we have now the lifestyle diseases. Okay. So a country like ours, with a population of our size, with the economic diversity that we have, not to have the building blocks, we'll never be able to catch up or where we want to be. What we are doing today is our whole thought process is intervention. Okay, people are not don't have enough money, let's give them this sucker, that scheme. Yes, these are all required, but you must have a global plan, global Indian plan. So if you look at carefully at Ayushman stack has been built very well in its concepts. Before Ayushman are two schemes already, Swasth Bharat and Swachh Bharat. You'll be surprised that there is no connection between the three. So I'm saying first comes health, wellness. That means if we can effectively put enough resources and training and attention to that part, 50% of our disease burden will go down. That means that you will not only have less sick people, but healthy people who are a great workforce. Because today, if you estimate the number of days spent, if somebody calculated in dollar terms, close to $300 billion worth of man days lost because of ill health in India. So if you have that kind of slum sitting in front of you, which you can fix, we can fix together. From there, we go to the wellness center where we can do a lot of preventive disease, early detection, sending people to the right facility at the right time. That system which is broken today needs to be strung together. So that in theory, it's already there. But the point is, can the government do it alone? Should the private sector and government work together and the NGO sector should work together? I think that's where the whole answer lies. Today, there is a trust deficit. There's always the private sector is overcharging. They are making huge sums of money. You look at the health of most of them. One or two of them are doing very well on the stock market, but the rest of underneath all that is pretty close to the ground. You understand? So we need to define one. Okay, what is the real cost of delivery of healthcare in different areas of different kind of facility? A nursing home, a small hospital, a secondary care hospital, a tertiary care hospital, a super tertiary care hospital. This needs to be stacked. Actual costing done in broad daylight by everybody, private sector and government sitting together. Then you realize you have a cost structure of delivering healthcare to the country. And then you put in the solutions at different levels. So if you ask me on top of my head, primary healthcare is always the responsibility of the government. Ayushman Bharat has been a big contribution from the government in trying to provide relief to the people who are below, who are really in trouble. And I think that private sector and government sector should work together and help them. But if there are procedures in there which are below cost, nobody can. Money is people's money. So realizing all these things and have one authority, National Medical Commission has been formed. Get people's representatives, responsible representatives from every sector. And you are seeing on the screen very senior people who are very well balanced in the sense, let's find the solution to healthcare India. So I think that if we break down the barriers, and COVID, by the way, has made it possible for the government and private sector to work together, actually together hand in hand. Now, the point is that if the regulations are clear, if the costing is clear, then you can do the penalization also if anybody violates those agreed upon rules. Today, the point is that there are unrealistic facts coming out which says, oh, you can do a bypass surgery for 1 lakh of rupees. Yes, you can do it, but your complication rates and the materials that you read are so substandard that does the poor man's life, in my opinion, a poor man's life and a rich man's life is the same. No question, there should be no distinction. How they are covered by what insurance and how much they pay, that's a different story. So let the people who can pay take care of themselves. People who are in the middle, provide them with schemes which will make it affordable for them, and do free treatment from the government for like what Ayushman has done. I think if we live, we will have a good system we can be proud of, and there are two parts to it. One, what we can do for India. There are 4 billion other people who are waiting for a model like that. That will be the soft power of India to be able to hold this up as a model for the rest of the world. Because everybody is struggling. There's no country which has got an ideal healthcare system today. Absolutely not. So if that's the tenet, the only thing, sincerity of thought, transparency, and execution by honesty. If these 3 things are the central pillars on which we build the healthcare system, we shall have something to be proud of within the next 3 to 5 years. I think 2 things will happen. If we reduce the disease burden, 50% of the capacity is already spare. Second, if the government and private sector work together, there is enough capacity on the ground to provide 50% more care for our patients. We just need to find that system.
Right. So transparency and working together with the government, really, those very 2 important issues. Dr. Sudarshan, working with the government now in Karnataka, there's been a lot of also debate on the price caps and pricing of, during the pandemic. So what are your thoughts and your suggestions on that front?
No, I think Dr. Trehan has covered many of the important points. No country can afford to treat everyone who's ill. So we should prevent illness rather than start treating illness because it's awfully expensive and we cannot manage that. So the government and we should work together to create wellness rather than treat illness. And as far as Karnataka is concerned specifically, I think the government has been very proactive and in fact has had an excellent relationship with the private sector from the time the first case of COVID was detected way back in March or late February. There have been multiple meetings with the private sector, and at no time was there any kind of pressure or harassment. And it was an equitable distribution of patients. Even just a few days ago, when the number of COVID patients have come down, the government has said now there's no need for you to reserve the beds. Only if the government sector is full, we transfer the patients to the private sector. But in case there is a second or a third wave, we will give you 5 days notice to get the beds back. So they've been very reasonable. The few points that I wanted to make is that, as was mentioned by Dr. Trehan, I think the costing of treatment needs to look at not just the price of a procedure, but also the quality and outcomes. So you can do a procedure for a very low amount, but the outcome will be poor, and in the long run, it will hit the healthcare of this country. So I think we should look at costing and quality together, not just the cost of a procedure or a price of a procedure, but also the quality. The other thing that was done, we need to look at is when they brought in capping of prices for COVID, they brought it universally. I don't see why a rich man should get subsidy from the government. If a rich man gets the test as the same as the economically weaker section of the society, doesn't make sense. So I think some form of cross subsidy should be there. And there are multiple ways of determining how well-to-do you are. The government has multiple schemes. Because here, a businessman and a ward boy were given the same price for COVID care in the ICU. That doesn't make sense. And ultimately, many a time, the private sector was losing money in the care, which could have been easily cross-subsidized. So that was another suggestion we had given to the government. And overall, I think unless we learn the art of working together and come up with a reasonable costing for a given procedure, whatever schemes we bring in will not be very widely accepted.
Right, cross subsidy. That's again very important. I get the point that there are different kinds of patients, and all cannot be treated at the same price. Dr. Shetty, how do you respond to that? The issue of costing and pricing that is now sort of again being restructured, and the fact that now one has to work with the government. You all have to work with the government to ensure that the treatment is affordable and also works economically for you, for your business.
So I think both Dr. Trehan and Dr. Balal have touched on some of the key issues that are there. I think the primary and the fundamental issue still remains that there is a huge amount of trust deficit that exists between the public and the private sector. And this is further kind of escalated by some of the articles that get covered. Bad news about healthcare always makes it to the front pages of newspapers. The good news is somewhere languishing in the inside pages. So clearly what happens is this trust deficit has to be reduced. I don't think it's going to disappear overnight. And this level of engagement that we see now during the course of the pandemic, I think is a step in that direction, because at least the government is also beginning to get a sense of what all is involved in terms of costs as far as the private hospitals go. The most important element is that rather than just putting arbitrary price caps, it's very, very important to do scientific cost-based pricing. And that I think is most critical. And the government hospitals are also running, they're treating the same set of patients. And one can pick up from their costings. There are industry bodies like CII, FICCI and all who have done costing exercises and submitted to the government. So rather than have arbitrary price caps, I think it will be extremely useful to do cost-based price caps, because that I think will make it equitable across the various sections. It will be fair to everybody. What we as private sector do realize is that in the course of the pandemic, it may be important to have price caps, because India is such a diverse country and you have all kinds of healthcare providers, and it may make sense to have some kind of price caps. But to be objective, it has to be cost-based price caps. I think that is what it is. So my two important issues is to reduce the trust deficit as well as to go in for costing-based capping rather than just arbitrary caps.
Right. Dr. John, now you've heard our industry leaders talk about costing, and almost all of them brought up the issue of the trust deficit. So there seems to have been an issue of perception amongst patients, and the divide between what patient expectations from hospital treatment and costs are, and what the understanding of the hospital system or the management or the economics of it is. So do you think there's a need in India right now to work on this trust deficit, and also to increase transparency? How would you respond to these key issues that our panelists have brought up?
Thanks, Namita. I was listening very carefully to each of speakers. Between them, we have, I think, more than a century of man years of experience as far as hospitals and healthcare are concerned. And so anything that I'm going to say is going to be tempered by the recognition that there's volumes of experience and wisdom. Let me pick up with what Dr. Sreehan started off. This opposition, not opposition, but opposition of transparency versus affordability. And I don't think we need to conflate the two things together in a conflict. I think those are conversations that need to be had. It's not going to be one versus the other or one over the other. They need to be done in parallel, in sync, because if you kind of say transparency, because we know this is our cost of goods or this is our cost price structure, and so therefore you buy it, isn't going to really help somebody who can't buy it. And so therefore there needs to be a conversation around affordability, which may not be possible the way we are doing things. And so therefore we need to kind of step back. I'm sure Dr. Balal will echo what I'm going to say next, which is that if we have picked up very early on somebody's urine sugar and his creatinine and microalbuminuria, you have probably the chances of averting some level of renal damage very, very early on. And what am I leading up to? Which means what I'm leading up to is if we have to think affordability, we have to look at not the way, Dr. Santosh Shetty, you've said that we have tertiary level services. We'll have to begin taking the lifestyle diseases or the cardio, renal, pulmonary, hepatic, metabolic complex, and we'll have to put them into the primary care thing, which is where Dr. Rehan had mentioned about Ayushman Bharat. Is it signaling out an early preventative perspective, or is it basically saying, hey, look, you can encash 5 lakhs from somewhere for something that's far too long gone? We need to begin messaging out from the highest levels, from each of you and from every one of us, that there are things that need to be picked up very early on. Primary care is not just about maternal newborn child health care. It is about picking up very early derangements and diastolic pressures, very early signals that we have got a deranged metabolism going on that will down the line impact your kidneys, impact your liver, impact your cardiac functioning. And so therefore pick it up early. That instead of us trying to replicate the 3 of them and their institutions per district, it's going to be frightfully expensive to get this kind of experience, which is what everybody should deserve. I mean, it's hard to do that, hard to replicate each one of them. What we can do is we can tear it down, stem it up early, because we know that who are the people that are most affected right now by the COVID surge. Any infective pandemic that's coming along, again, Dr. Santosh Shetty, you had mentioned the lifestyle pandemics. No, I mean, they're basically like a forest that's very, very dry. One spark and the whole thing is going to get set on fire. Let's address things very early on so that when a surge capacity comes, when a challenge comes along like COVID, it does not affect people who are already on a continuum of metabolic or systemic disorders. They are the ones that are toppling. They are the ones that are most likely to need the highest levels of care for rescue. And so therefore, is there a lesson for us to go forward? The lesson is not about the affordability, transparency, cost of goods, trust deficit. Those are all there. Those are all symptoms of what we need to address. The current infrastructure, the current doctrine of health that we have from 1946 onwards has been done in a particular way. I don't think it's fit for purpose anymore. What we need is renal care, cardiac care, pulmonary care, hepatic care at the very earliest, closest to where the person is. Can we pick up signals very, very early on to where I'd started off? If we can pick signals of derangement early, do we need then interventions that are early on, thereby relieving pressures further up the line? And in the process, we will create more capacities. But is there a time, is this actually forcing us to rethink how we are going to deliver services? A safety net is no good if it's only 2 feet off the ground. If you're falling from 200 feet, you're going to get hurt. Is the safety net going to be further up? Is it going to be so far up that the parachute does not kind of open up? That's a different story altogether. What is that optimal conversation? That's where I would look to the private sector to say, look, we know what works. We know these are costs of goods. We can't afford it for 1.4 billion people. How do we minimize or how do we optimize that flow in such a way that you are not looking at the most expensive way of delivering healthcare? The most affordable way of delivering healthcare is by figuring out how early we can intervene. And that's where I would look to the wisdom from each of the co-panelists and many others like them, leaders literally, who have set up flagships to basically come together. We have to get to the art of working together. This is not about public sector, private sector. This is us together. Because when a fire happens, it's going to burn everybody, as we're experiencing right now. And that's where I think the opportunity lies, and we need to take advantage of it.
Absolutely. Thank you, Dr. John, for bringing up, and also the other panelists for bringing up the point of prevention and early care. I think I've lost count of the number of discussions that have closed on this point. We need early care. We need to go back to the basics. And while the government has, made all the right noises about it with Ayushman Bharat, and it's trying really to get that done, it's been slow on the ground from what we understand. And I guess we would be looking to, the years of volumes of experience we have here to really work with the government and ensure that these things take off. I mean, we've been hearing and we understand it now, and as you reiterated it, but we really need to see things going so that that gap is bridged, so that once one goes to a hospital, one is not hit with this huge sort of bill, and that takes you back, and then you don't know what to do, and so on. We did have questions, but I'm told we're running out of time. Thank you to everyone who took out the time on a Monday morning to speak to us and enlighten our audience. And as the search continues, I guess you'll all be on the spot. You'll all be fighting this pandemic, and as much as we can talk about it, you're the people who are doing it out there in the field through your staff, through your colleagues. Thank you once again, and we look forward to engaging with you in the future as well. The Week magazine is extremely fortunate to have you today. Thank you very much. I'll hand it over to Matthew.
Thank you so much, Namita. Thank you so much, Dr. Shetty, Dr. John, Dr. Balal, Dr. Trehan, on behalf of the editor of the week, Mr. Philip Matthew, and everyone else. I thank you so much for taking a big chunk of your Monday morning to be with us. I know it's a busy time and a busy start to the week. Thank you so much. Only about 10 minutes more left in our webinar. And next up is our survey partner, Hansa. From there, we have Mr. Bikash Padi, Research Director of Hansa Research, who will put the survey and research methodology and the survey itself in context. Hansa has been our partner for about 6 years now. Thank you so much, Team Hansa. And over to you, Mr. Padi.
Thank you, Matthew. And thank you everyone present here for contributing to our lives and well-being in a selfless manner. It is actually my honor to be here with you to celebrate the achievements of the healthcare service providers. The Week Best Hospital Survey has been recognizing the efforts of healthcare service providers since last 15 years. While I truly believe that every healthcare provider is a savior and winner, what this survey does is the survey aims at recognizing those who are going extra miles to excel and become the torchbearer. Over the years, the ranking process has strived and evolved to constantly be reflective of the ground reality. It has become the most credible healthcare ranking widely accepted by the industry. continuing our endeavor, this year we have taken a step forward and coming together to facilitate the top healers for their efforts. Before we go to the award or to basically announce the award, I would like to take you all through the process and rigor behind the selection of the top hospitals. When it comes to ranking, for an accurate assessment, the ranking should be based on a robust evaluation process. It should have the strength of quantitative numbers along with the depth of qualitative inputs as well. The foundational thought behind this ranking is the fact that the work done by one is always noticed, evaluated, discussed, and appreciated by the peers. So, to taking our decision from this thought process, we wanted to leverage this knowledge. We start by asking physicians to share their opinion on the best in their arena and nominate the top hospitals. Not only do they name the best, but also rate them on important parameters. Nominations and ratings are taken separately for multi-specialty hospitals and specialized hospitals to do justice to their distinct presence. The data accumulated from over 2,000 physicians is carefully assessed to shortlist the top hospitals for this year. This itself is a daunting task, especially during this pandemic time. But the process doesn't end here. What differentiates this survey from other studies is the multiple layer of validation. We believe that discovery of India's best hospitals should have a human touch. Post receipt of initial responses from the stakeholders, we embark on a journey to get underneath the quantitative data to enrich and validate it. Each hospital that feature in the ranking goes through multiple levels of validation through the data collected from secondary sources and factual information submitted by hospitals themselves. The near final ranking is then taken to healthcare experts and opinion leaders who guide us on final nuances. When I say final nuances, their views on what makes a certain hospital better than their peers, like academic prowess, cutting-edge technology, availability of better team, process and model adopted by a particular institute, the list goes on. But all these parameters helps us in actually making this ranking even more credible. 2020 has been a different year and presented us with a unique set of challenges owing to the pandemic. Experts whom we regularly meet for the validation process, they were extremely hard pressed for time, considering the fight they were and still are putting up. Despite this, I'm telling you, despite this, we got overwhelming support from both in terms of hospital participation and healthcare professionals during this entire process. Some of the experts even went to the extent of giving us time in the early hours of morning or very late in the evening because they wanted to discuss at length. They said, we don't want to just tell you like in 4 minutes or 5 minutes, like these are the rankings. No, we want to tell you why a certain hospital should be there and what are the particular reasons for that. And I think that will help us. And we have received this response from across cities, like across premier institutes, be it government or private. We would like to extend our heartfelt gratitude to all of you who have supported, guided, and encouraged us. Thank you. Have a good day. Stay safe.
Thank you so much, Mr. Padhi, for the crisp summing up of what is a very comprehensive survey. Thank you for partnering with the week and all the help that we've had from you over the years.
Welcome.
Now on to the week Hospital Survey Awards 2020. It will be played out as a video. It's under 5 minutes as a video announcing hospitals by regional and national rankings. After that, we'll come to an end with just a word of thanks. Now over to the tech team for the video. This is the end of the ceremony of this morning. Thank you so much to everybody for taking time out to be here with us today. On behalf of everyone in the week, please accept my deep and sincere thanks. I'll just take a minute to thank all the panelists and the keynote speaker. Thank you so much, Dr. Guleria, for being generous with your time. Thank you, Dr. Shetty, Dr. John, Dr. Balal, and Dr. Trehan. I'm borrowing a line from what Dr. John said, that we had over a century of medical experience on the panel, and that was there to show. Thank you so much. I know your time is precious, and I hope you'll get about 30 minutes before lunchtime in your day. Thank you, Mr. Padi and Team Hansa once again. Last but not the least, my sincere thanks to my colleagues in Bombay, Delhi, and Kochi for all the hard work in putting this together. Thank you all so much, and have a great week ahead.